Hey everybody, we're just going to wait a couple minutes for a few people to join in and we'll go and get started here. All right, hey guys, welcome back. Thank you so much as always. The support has been amazing. You guys are awesome, always tuning in. All of the positive feedback we get through, video, Instagram comments, DMs, all that stuff. We really appreciate. Y'all are awesome. But so we should have a lot more PAs coming through in November. I think I talked about it last time. It should be a busy month for us. We will, our next section after this one is going to be on Friday. So stay tuned for that. We'll let you know all the information and then we'll try and keep you posted through Instagram. I know you guys were wondering about the quiz, so I'll let Alia talk to you about that.
So as always, it'll be at the end of the session. It'll be 5 multiple choice questions. It'll be open for an hour, and as long as you get 4 out of 5 correct, you'll get the certificate.
Perfect. And we will tailor the certificate to however long the presentation is today. So for example, if it's an hour long, we'll put an hour on there. If it's 2 hours and so forth, we'll kind of adjust it to however long we go. Let's see, there was something else. Let's see. What did I say? I forgot. Oh, right. The chat. So Peter will be watching the chat. So if you guys have questions anytime, as always, we try and promote, we want him to be able to feedback and kind of talk with you guys directly. So if you have any questions or, just want to say something positive or anything at all, really just please be as active as you like to be in the chat. We love to see that. But yeah, guys, I think that's everything. We'll be hanging out here, but Peter, if you're ready on that side, it's all you.
All right. Hold on. So, I'm just trying to hit the live portion on my iPad.
Oh, you're good.
Well, this is very trippy. Okay, cool. So do I just hit like screen share and then pull up my PowerPoint? Is that what I do?
Yeah, exactly.
Sweet. All right, let me pull up my PowerPoint first.
Oh, perfect. Looks good.
Does that work?
Yeah.
And then how do I view presentation mode? What is it?
I see a play button at the top. That might be it.
That's cool. If this works with y'all, works with me.
Yeah, that's perfect.
That cool?
All right. All
Okay.
you.
So I am Peter. I am very happy to be here right now, and I appreciate the Pre-PAPals having me and reaching out to me, inviting me out. I wanted to do a PA virtual shadowing, but this is a little bit different. I wanted to throw in some minor details and nuances to kind of make this more of a like a ride along. So this is kind of like the experience you would have with me if you were a student at Hipside, you know, in clinic with me and whatever. So I wanted to make this more personable, a little bit more intimate virtual shadowing than the previous ones I've done. So that was my first mission. And then, of course, you know, I just wanted to make this virtual shadowing informative, but still kind of entertaining and fun. And so, you know, this is like popcorn talk to me. I don't expect anyone to take notes or anything like that. I just want this to be chill and pretty laid back. So come on into my ride along. Let's see. Okay, so a brief introduction about myself. I am from Dallas, Texas, born and raised. I went to undergrad at UT Dallas, and I got a degree in healthcare studies, whatever, you know, just get a degree for PA school that you need, any. And then I went to PA school at UT Southwestern in Dallas. So that was my first pick school. And so I was pretty stoked whenever I got the acceptance from that. And ever since graduating in 2018, I've been practicing in gastroenterology and pretty happy with my pick. That's one of the elective rotations that I selected too. So I kind of knew I had a natural, like I gravitated toward gastroenterology. And, you know, I like to share some things outside of medicine because I love work, but I don't live to work. And so I like here in this picture, I'm at Yosemite, and it was one of the most stellar views ever after scaling Half Dome and the actual cables and everything. So you're at the very top. And so I like to stay active. I like coffee. I like my AeroPress on weekends, and I like sharing about financial stuff and talking about that with my students and all. So, and that's the beautiful Dallas skyline that really nothing compares to. And then a little bit more about PA school as far as UT Southwestern. It is ranked pretty high up there, and I only put that not to brag, but I wanted to make a statement, a firm statement actually, that it really doesn't matter what school you go to, because at the end of the day, as long as it's credited, right? Like you're getting a certificate, you know, or a diploma, right? We're all taking the same freaking pants exam. And so what really matters is at the end of the day, we're wanting a job and a paycheck. And so none of the potential employers that I interviewed with or, you know, applied for a job to really didn't give a damn about which school I went to. It's all about experience and who you know. So yes, you know, UT Southwestern is renowned. It's highly ranked. I can see why people want to go there, but just go to a PA school and get the most out of it, and then continue to network, and just, you know, don't hold out for that top ranked school just for, you know, the prestige and the title. At least I don't think it's worth it. It's also very affordable here at UT Southwestern, and I think Texas in general. And so we are pretty badass in that sense. So tuition and fees and stuff, everything comes out to about 40,000. And if you do get a chance to interview at UT Southwestern, it is a multiple mini interview session. So it's really no way to prepare for it. And it's very frustrating because the only practical tip that you'll get from students and alums and all that is to really just be yourself, smile a lot. And, you know, once you mess up on a station, because you probably will, you just got to, you know, move on and carry forward with grace and stuff. So easier said than done. And then another thing is rotations. When you're in your clinical block or clinical phase of PA school, it's all pre-assigned to you. So that's pretty cool because you don't have to stress about finding preceptors and then finding housing and whatnot. It's all kind of done for you. So that's a huge burden off of your shoulders. And then it's about a 30-month program, a year and a half. And then let's see. Yeah, my 2 elective rotations were gastroenterology, and I thought I wanted to do peds, but like I really don't like the infants and toddlers. They just never really wanted to take good care of them because they kind of freak me out. But I still like peds, just not the youngins. And so right now I practice in gastroenterology. And so just a little brief synopsis on gastroenterology. We specialize in digestive issues. So we are treating things from the esophagus to the anus. So, I mean, your GI tract is pretty long, right? It's a big old donut hole, if you will, including your liver, your pancreas, whatnot. So what you would probably want a GI person on your team for is our endoscopy, our scopes. So I'll kind of brief you guys on this later on, but there's an upper endoscopy to check your upper GI tract, your enteroscopy, your small bowel, colonoscopy, EUS. So just a lot of different cool procedures that we do. And then you can also subspecialize within GI. So you can kind of go even more down the rabbit hole. You can specialize in esophageal disorders. Liver hepatology is its own thing, really heavy on the transplant side. The pancreas people, inflammatory bowel disease, it's just a whole thing in itself. And then even functional disorders like IBS too. So it's very, I like the broadness of GI, but I also like the depthness of how narrow focus you can go. And disclosures, I don't have anything. No one is paying me for this. I don't know why. But yeah, I'm just kidding. Okay, so you're shadowing me, each and every one of you, and so you're shadowing me. I kind of give you a brief synopsis of what that's going to be like. So we will be starting clinic today at 8:30 a.m. That's when I start, and I always tell students, this is the time that I start, but if you're on time, then you're already late. So expect to come at least 15 minutes early. Okay. And that way you can get situated, I can get to know you, and we can kind of just run through how the day it's going to be. I can show you around the clinic. We could kind of talk about some of the cases that I have if I have time to look up the patients beforehand. I will request that you bring a laptop. I don't know if all the other preceptors are like that, but I like to have my students look up stuff and keep busy sometimes. So it's absolutely okay to bring a laptop, just as long as you're not always on Facebook or, Instagram or whatever. And then, of course, you want to bring some questions just in case we have some downtime. And then lunch, I always try to get you free lunch, whether it's in the physician lounge or if reps come and bring us lunch or whatever, a smoothie or something like that. I try to hook y'all up. So you don't have to bring lunch. I got you. And then, so you're coming into clinic, you're like superb, you're coming in on time, it's 8:15. I introduce you to everyone, including the MAs and the nurses and stuff. So my piece of advice is that you can always learn from everyone, not just the APPs, not just the docs, but everyone from the front desk to the staff, the MAs, the nurses, because if I'm still learning from them, as far as the logistics and what perhaps what one of the doctors might do or something like that, just curious to get what their input would be, then I think certainly you can learn from them too. And that's something you can take to whenever you're in clinicals too. So especially if they're senior members there and they've been working with the docs for so long, I mean, they kind of just know how the docs or the providers function, So we introduce you to everybody, and then, we get settled in. It's 8:30. Patients are never on time. So really, we're starting about 8:45. So we're already behind. So let's get to it. All right. So our first case of the day in clinic, okay, it's going to be a 47-year-old male, history of GERD. He was referred here to our GI clinic for epigastric pain. So that's sitting below your breastbone. Okay. So your mid upper abdominal area. And he complains of nausea without any vomiting and some just generalized bloating. bloating is a symptom and distension is a physical sign, right? So he has this symptomatology for the last 3 months, and he's noting that it's worse with meals. We can't really figure out a pattern associated with any clear foods. It's just kind of eating in general. He takes BC powder twice weekly for headaches. So, I just want to pause real quick right here. So in the GI world, we are always harping on the NSAIDs, right? Because they're over the counter. And there are things like ibuprofen, Motrin, Advil, Aleve, naproxen. And I always throw in BC powder too, because people don't realize that it's also an NSAID by trade. So that's something we always ask about, right? Because the NSAIDs can affect your GI tract essentially from, esophagus to anus, right? Can cause irritation, inflammation, predisposes you to bleed more technically. So we're technically anti NSAID and GI. Anyways, so you elicit the ROS. And so he has no fevers, no weight loss, no anorexia. So no like decrease in appetite or anything like that. He doesn't have difficulty swallowing. That's dysphagia. And there's no signs of a GI bleed, meaning he's not throwing up blood. He's not throwing up coffee ground looking vomitus. Okay. There's no like bleeding from the rectum or any black tarry like street tar like stools. That's what that means, tarry. And so there's essentially no lower GI symptoms. And then he's a tobacco user for the last 10 years or so like that. On exam, his vitals are stable. Exam, he's looking pretty, just normal, healthy looking dude. So at this point, we need to think about a differential, meaning a list of things that this could be. So maybe this is a good time to think about a differential. So I look at you and I say, what do you think? And you tell me, and I'll give you guys a second to think about it. If you, I guess, would they like just type it in the YouTube live chat thing?
Yeah, exactly. You should see it pop up here in just a second.
Okay. Let's see. Yeah, so Maria says an ulcer. So peptic ulcer disease is definitely, I buy that. It's definitely high up in the differential. How about one more? All right, well, yeah. So an ulcer is definitely on the differential. H. pylori is, you can lump that in together too. That's another cause for ulcers, okay? Diverticulitis, you would think they would have more of a lower abdominal pain classically, because mostly it occurs in your sigmoid colon, which is the left lower quadrant. But you technically can have, diverticula across your whole colon from the right to the left side colon. Other things you might consider is gallbladder issues. Okay, so technically it is classically in the right upper quadrant area, but you can have referred pain to the epigastrium as well. Postprandial symptoms, meaning after eating, abdominal pain. You would kind of think, that it could be gallbladder related. Maybe it's not acute cholecystitis, but it could be biliary colic, meaning you have some gallstone issues, symptomatic gallstones. It could be more of a latent chronic cholecystitis even. Let's see what else. Yeah, it could definitely be reflux, pretty bad reflux causing all that. It could be IBS stuff, so more of the spectrum of functional disorder. So this could be a functional dyspepsia. So great, good stuff, good stuff. So we kind of have a list of things that I like. You can always throw cancer at the end of the list because that's always on the differential. So good job, everyone. So we kind of have a plan or a list of things we think it is. So let's get some basic labs. Okay, so the way I'm thinking about this in my head is really the chief complaint is the epigastric pain. Okay, and so revolving my head around that, I kind of order the same test for abdominal pain. And so that would be your CMP, your CBC, TSH, lipase, and celiac. So I'm pretty sure the past PAs have showed you what a CMP is, CBC and whatnot, but I guess kind of what I'm more so looking for, is in the CMP is I'm looking for things like signs of infection. Like I look at the white blood cells too. I always just look at the platelets. I don't think this is like liver related, but I glean on that too. Hemoglobin I look at all the time because anemia, iron deficiency anemia is something big in the GI world. So I make sure, he's not anemic, that he doesn't have this occult bleeding or anything like that that could be going on. He's okay. CBC, oh shoot, sorry, that was the CBC that I was talking about with the platelets and the hemoglobin and whatnot. The CMP, of course, I'm looking at liver enzymes, AST, ALT, and things like that. Looking at electrolytes and everything too. The TSH, I'm looking at thyroid just because it's cheap, easy to treat. And so it can cause GI symptoms, diarrhea, constipation, abdominal discomfort, whatever. So I always lump that in. Lipase, we're looking at the pancreas. I doubt this is an acute pancreatitis episode, but I'll still check the lipase. And then, which I should add, the pancreas should also be on the differential too. Pancreas etiology, I didn't mention that. And then celiac panel. So in the GI world, we treat celiac disease and autoimmune gluten insensitivity. So I'll order a general screening for that. So these labs are truly what I would order if this patient was actually real, as my general like abdominal pain serum workup. Okay, and then next we can. Someone says order EKG. Yeah, so if this guy had more chest pain, or if I elicit more history, sure. But he was referred to me from his PCP, so I hope the PCP ruled out any chest concerns, right? So I'm just going to assume that. But yeah, in the GL world, if you do have chest symptoms, sometimes it's hard to delineate between if this is like reflux or is this an actual cardiac condition. And I mean, you'll have people go to the ER, right, for chest complaints. And dude, you say chest pain, everyone is on you with the whole workup and everything, troponins and EKG, watching you and whatnot. And then sometimes by the end of it, it's negative and you're giving them a GI cocktail and they say they're feeling better. So it's, by definition, it's non-cardiac chest pain. And so, but always should never feel shy to refer to your cardiology colleague to make sure it's not heart related. Good thought. So I ordered the basic labs, or we order the basic labs, and then we can consider imaging too. We can get a CT imaging, but he tells you that, oh, hey, actually, my primary care doctor ordered a CT a month ago. So, sometimes I think it's just make sure, hey, did you ever get any recent imaging done to kind of gauge, should I order one now? Or, I mean, can I wait until after? And so let's see, he's a good patient. He kind of tells you, my doc told me it was fatty liver and some diverticulosis, but I mean, it was pretty much otherwise normal. And so, I mean, that's why he's here in your clinic, right? So we got some labs. We document that he had some imaging done too. And so what would you guys think would be the next step, or what would you want to do next? No, right or wrong answer per se. And we have to send off our labs. We don't have imaging. We don't have labs in the clinic. If you guys are looking ahead on the slide, you might know what the answer would be, or what I suggest we pick next as a next step. Okay. So I order an endoscopy. Okay. And so I guess we did list gallbladder as our cause. So yeah, we could have ordered an ultrasound then, or we could have done this EGD first and ordered it after. So it just kind of depends on what's your pretest probability, meaning do you suspect that it's really that or not. So in this case, it's been happening for 3 months and he's okay. So he looks stable. He's not nutrient deficient looking, whatever. So anyways, we will order a EGD, or commonly known as an upper endoscopy. And so we set him up for that. in the GI world, as a APP, as a PA, we are not generally involved in the procedure, in the procedure room, in the OR. We mostly do clinic stuff. So very few people I know, as APPs will do an endoscopy. So we order it, and then our attendings will take care of it. So we order the upper endoscopy. And so, that's because we want to take a look down the GI tract, the lumen, right? We're looking for luminal diseases and whatnot to explain what's going on with it. So basically what an upper endoscopy looks like is, if you see right here, you're going to have the patient lay on the left side. They're completely sedated. And then you stick this long camera down them. And so honestly, between like what endoscopy looks like or colonoscopy and whatever, those scopes all generally kind of look the same. It's just the title really denotes what area you're looking at in a very simplistic way to explain things. But we get to look down there. We get to look at the esophagus down here, the food pipe. We get to look at the stomach right here. And then the scope actually reaches just enough to the first part of the small bowel, right? The duodenum right here. So it's a really good look of the upper GI tract, i.e. it's an upper endoscopy, right? And so someone mentioned biopsies. So yes, the endoscopy is very dynamic. So it's diagnostic, meaning we look down there essentially with a naked eye, right? I mean, you see the camera projecting the image onto the screen right here. And so we get to look and see, is the esophagus or the stomach erythematous, suggesting a gastritis or esophagitis. We get to see if there's ulcers in the esophagus, if this could be herpes infection or CMV. Usually that's an immune compromised person. We could take biopsies of things too. So we could take biopsies of the esophagus, and that can lead to a diagnosis of, does he have Barrett's esophagus? Does he have Candida esophagitis? So essentially like a yeast infection, okay, of the esophagus. We look in the stomach, and so that's definitely how we would diagnose H. pylori, right? H. pylori is a little bacteria that can thrive in the stomach, okay, and its acidic properties. It thrives down there. And so we could take biopsies of it and look under a microscope to see, is it truly positive for this bacteria infection? And if it is, then, we're on it. We are devout on killing the H. pylori bacteria. So, and then we can look at the small bowel, the duodenum. In the duodenum, we can screen for things. You can also have duodenal ulcers as well. Okay. And you can screen for things like, not screen, but diagnose celiac disease, right? So you take a snippet of the small bowel, and then underneath the microscope, if they show that the villi, so your small bowel looks like that, right? Little finger-like projections, and it looks, I don't know, like, in SpongeBob, that little wavy thing that always would do stuff like that. Like that's kind of what it looks like. But if it's blunted, meaning, instead of all finger-like projected, it kind of looks, like blunted, right? Like flat, with some intraepithelial cells, like white blood cells attacking it and whatnot, because it's autoimmune in property. And then we're suspecting celiac disease to explain the symptomatology. So, and with that said, an upper endoscopy is also diagnostic too, meaning if there was a GI bleed, if there was a gnarly ulcer that was bleeding, which in this case is probably not, because he would have showed signs of bleeding, we can clip things, like we could clip a blood vessel that we see. We can inject epinephrine and kind of, what epinephrine does naturally, right? It constricts the vessel so it can stop some of the bleeding. We could cauterize things, meaning we could kind of burn off the bleeding vessel and whatnot. So a bunch of cool stuff that we can do with the endoscopy. Yeah, the dude, the dude is wide awake. So I think they need to push more propofol and Versed in his ass, but whatever. So anyways, our attending does the EGD, and then he does find, it takes a few days for the pathology results, right? And then he does find, oh shit, this guy has H. pylori. So generally after that, he'll see me back in clinic for the follow-up after the procedure. Okay. And so now we are, let me see. Okay. So treatment of H. pylori. I love to bring up H. pylori because it's super simple as far as like in PA school and the pants and whatnot, because we're taught to treat it with CAP therapy, which is clarithromycin, an antibiotic, a second antibiotic, amoxicillin, and a PPI, which is a P, right? So like pantoprazole, for example. That's like the easy answer. That's probably what you'll see in the pants questions, if I'm not mistaken. But I generally shy away from it. There's just increasing resistance. Um, probably at conferences you'll see people talk about your community bacteriogram and stuff. Like I don't even know how to look that up, and I don't think most people do. So I just, cap therapy is kind of like, I would only consider no, I would consider cap therapy strongly if it's more of a cost burden and insurance is giving me the ring around and stuff like that. But I try and I'll go to bat for the patients to do the better alternative, which is a bismuth-based therapy. Okay, so you'll learn about H. pylori later on, but in the real world setting, if you want to take just an easy message to remember here on out, you see H. pylori, the first line treatment, almost always the right answer will be a bismuth quadruple therapy, right? First line between, this is the first H. pylori infection, bismuth. If they're allergic to amoxicillin, bismuth, right? If they tried cap therapy and they failed that, bismuth therapy. So, at least in the adult population, I don't know how to do it with the kiddos, but yeah, I guess you would do cap on the kiddos. But bismuth quadruple therapy, H. pylori, link that together in your brain, and you can, take that to the bank here on out. So not only that, but you can do load therapy, Levaquin, omeprazole, Alinea, doxycycline. These are going to be your, the antibiotics that you use. Alinea is like, I think it's like an anti-parasitic properties or whatever to it. Concomitant therapy is cap therapy with flagyl added. And then there's also this bad boy on the market right here, Talicia. It's pretty cool. It's amoxicillin with the rifamycin based therapy, so rifabutin, and so it's newest way of treating H. pylori, and it's good that we're developing new treatments for it, because as resistance is catching up, we need to get creative in treating H. pylori. Okay, so the reason why you want to treat H. pylori too is because it can lead to cancer, right? That's why we test for eradication, right? Not like all infections, we test for that. Like C. diff, for example. If you were there for my C. diff talk, once you treat C. diff, for 10, 14 days, whatever, as long as you're not having diarrhea symptoms anymore, we don't care. We don't retest it. But H. pylori, we're pretty anal about it, no pun intended. But we want to make sure that we kill the H. pylori. So let's see. What did we decide to treat him with? All right, whatever. Let's just pick a therapy. And so I'm gonna pick Talicia just because I want to try something new. So we try that. Somehow insurance is like, oh wait, this is great. Let's go ahead and approve of that. So he gets Talicia for about 10 to 14 days, and he tolerates it well. If you're gonna treat a patient with that, you're probably in GI, but it's gonna turn their I think it turned their sweat orange, but definitely their pee, right? Their piss orange, red orange, whatever. So if that happens, you just want to warn them, like, hey, you just got to continue that. It's not dangerous or anything. So we treat them, and then, like I said, we want to test for eradication with H. pylori, and so we're gonna wait about 6 to 8 weeks post treatment, and then he's gonna be off of his PPI therapy at least for a week, if he even needs it. And then come back, do the breath test. It's like a breathalyzer, and you're gonna test the urea level to see if there are any signs of H. pylori. So we test him, and basically he's cool. So someone asked me what this was. It's a wrap, because we're wrapping it up, right? So I want to talk quickly about ulcers and ulcer diseases, right? Ulcers can be from H. pylori, like in this gentleman's case, right? It could be from NSAIDs, which is why we always ask about NSAIDs, just almost always in the history if you're in GI. NSAID-induced peptic ulcers is quite common. Okay, so the treatment choice there is really to stop the NSAIDs. Maybe you want to give them a PPI therapy for about 6 to 8 weeks or something like that. And the PPIs are, I think there was a question about PPIs and whatnot. And let's see. Yeah, so PPI therapies, there's a bunch on the market. You probably see Nexium, you've seen Prilosec and their generic equivalents. I'm just gonna say, like, between the PPIs, there's no rhyme or reason to choose one or the other. I mean, really, the reason I would choose one or the other is just because, I just inertia. I generally use pantoprazole all the time, so I just stick with it. If insurance dictates things, then that's one thing to know. Sometimes patients just they just jive with one PPI than the other, then, inertia there. I don't want to, if it's not broken, don't fix it. But clinically, they should all work the same. And so there's no reason to really say this PPI is the one that I want you on, at least for the efficacy purpose. Okay, steroids can too. And so, I mean, some people, like your RA patients, they're on chronic steroids and then they're taking NSAIDs for the arthritis. So it's kind of like a double whammy kind of thing. And it just predisposes you to ulcers, right? The NSAIDs are antiprostaglandins. And so without the prostaglandin providing that mucosal protection, that barrier, that stomach acid is just going to eat up the gastric lining and cause ulcers over time. Physiologic stress, right? PPI are used as prophylactic agents, like in the ICU and stuff like that, when you're under physiologic stress, and just in critical health. Alcohol and tobacco use as well, and cancer too, right? So cancer can present as a gastric ulcer. So that's why whenever we take a biopsy of it, we want to make sure there's no dysplasia or there's no signs of cancer. And oh crap. Okay, so never mind. We chose bismuth quadruple therapy because I was getting on my soapbox for it. But yes, bismuth quadruple therapy is always the right answer. And so, well done. Good job. You learned something new. We talk about H. pylori. And so H. pylori is pretty important because you're going to see it in family medicine too. You're going to see it in pediatrics, right? And I mean, if you're in GI, you're going to see it in GI as well. Okay. How often would you have to take NSAIDs to get an ulcer? There's no rhyme or reason, really. I mean, if it's you're going to use that history to see, all right, should I scope this person or not, depending on how frequent their NSAID use are, and then the symptoms that they're having, and if they had prior EGDs done before and stuff. But I honestly don't know. Like, okay, NSAIDs every day for 2 weeks, and then that's when you definitely would get an ulcer. Or, I mean, is it the ibuprofen at 200 milligrams or 800 milligrams? I'm not sure what the definite amount and time link would be, but it's just kind of frequent NSAID use already predisposes you to getting ulcers. All right, good wrap. That was a good wrap. Delicious. So next, some intermission time. So you thought that was pretty cool. I'm like, hey, that was pretty cool, right? H. pylori. And then we go back to our office. I finished charting, but if you're ever shadowing me, I'm always behind. I think a lot of providers are behind, except my colleague Coy. He's really fast. He's always on top of it, making me look bad. But anyways, so if I don't finish that whole chart and sign it off, I'll just type in the diagnosis, assessment plan, and then just like finish it off later. My MA will ask, hey, are these to the patients? Are you comfortable with having a student on board? And boohoo, unfortunately, this next patient is like, no, I don't want another student in here. You already look like a student. And so, you just sit out, play on your phone, hang out, talk with the MAs. They're pretty cool and stuff. Get a snack, go to the break room, whatever. This is a really cute puppy, by the way. So that's why I put it in there. All right, cool. So, but I did manage to look at the next patient in case. And so I tell you that the next patient that we'll see after this grumpy old man is going to be elevated liver enzyme and the workup for that. So that's something that we commonly see as an outpatient referral and even inpatient consult too. So I really love the workup for it. I think it's a lot of fun. So get to it while I go see this grumpy old man for, I don't know, whatever reason. All right. So before, yeah, so I come back from the room and it was probably a hemorrhoid and he was too shy to talk about the hemorrhoid or whatever. I don't know. And so we have some downtime before seeing this patient, this consult for liver enzyme stuff. All right. So let's quickly talk about this. I have some time to teach. I love it somehow. And then somehow I have the time. And then so let's talk about the consult for elevated liver enzymes or elevated LFTs. You might see it abbreviated. So can someone give me an answer to how do you gauge synthetic liver function whenever you get these labs ordered? And let's just say it was based off a CMP, right? It was like a yearly routine lab that the primary care doctor noticed some elevated liver enzyme. So does anyone have any idea or wants to throw out a guess as to what lab marker on that CMP and CBC, right? That I could be looking at to look at the synthetic liver function? So somebody said elevated bilirubin. Cool. So yeah, I mean, you can look at the bilirubin too. You can look at things like the albumin because the liver is like a protein hub, right? It creates a lot of proteins in our body to utilize. It creates coagulation factors. So you can look at the INR level. I mentioned albumin, which is the main protein that's floating around in your blood, right? It's a transporter. It provides most of the oncotic pressure to keep the blood or the fluids inside of the blood vessel and not let it leak out, and perhaps third space into the legs, causing bilateral edema. What I see commonly too is ascites, all this fluid in the abdominal cavity. So albumin, I can look at the INR, I can look at the bilirubin, as you said, but that also can be, as you see down here, hepatocellular as well. And then I can look at platelets too. So, because your liver produces that. So I can look at those things, right? Function is what the liver makes or does, right? So next, let's ask this question next. What's the difference between cholestatic liver pattern and hepatocellular as far as what you would see on like the CMP? Someone says, Google says, that's right. Use your Google because you have your laptop with you, right? I love this. This is some real simulation right here. So yeah, some people are throwing out AST, ALT, the alkaline phosphatase. So whenever the AST and ALT are like really high, right? You're thinking this is a direct insult to the liver, hepatocellular in nature, which is this right here. And so, I mean, this is like saying the AST, ALT are like in the 500s, but your cholestatic refers to the alkaline phosphatase level, and the bilirubin. So if you're saying that it's a hepatocellular looking in nature, then you're telling me that the AST, ALT, which are the transaminases, they're far greater than what the alk and the bilirubin would be. Conversely, if you're thinking it's more cholestatic liver pattern disease, so you're thinking there's like an insult in the bile duct, right? I should have had like a diagram of the bile duct system, but whatever. So the bile ducts it's all that green tube that you see in your anatomy books, but you're thinking in the green tubes that's where there's an insult or there's a pathology going. So your bilirubin is like really elevated. It's like 5 or whatever. Alk phos is 250, but your AST, ALT is like hanging out in the low 100s or something like that. So, that's kind of how you would gauge things. And so good job, guys. And then last question before we go in and see this patient, because it's like, we're already behind. And so we don't need another grumpy old man. So the stigmata of cirrhosis on exam. So What that means is, what are the like physical exam findings I would see with a patient with cirrhosis? Is it's gonna look like this little ugly ass bumpy lumpy liver right here. So the liver on the left, it's smooth, it's glistening, it's prestigious, it's like Michelangelo's little creation or whatever. And then cirrhosis is just deep scarred, bumpy, lumpy, slightly contracted. That's end stage liver disease right there. So does anyone have any idea as to what I might find on the exam findings? I guess you can use Dr. Google and whatnot, since, you know, jaundice. All right, cool. Samantha, that's right. So jaundice is them looking like a banana, or like, as I call it, like a lemon head, right? And really, truly, like, they will be looking like a lemon head. Like, I remember I walked into one of the patient's room. I flipped on the light, and I was like, I know this is not coming from the orange glow from the light above and his eyes too. So when that bilirubin is up, usually it's going to be above 3 or so. The white of your eyes has an affinity for all that bilirubin, so it's going to deposit there. And I mean, that's what you would use if they have more melanin in their skin. You would look at their eyes to see if it's if it's like pretty and stuff and all white, or is it like yellow, and showing signs of hyperbilirubinemia. Very good. John is feeling enlarged liver on palpitation. Yes. Have I really felt an enlarged liver on exam? I don't know. I felt an enlarged spleen before. I'll tell you that. So splenomegaly, possibly. But let's see. Yeah, I mean, you can have ascites too with the cirrhotic. So all that swelling into the abdomen is all that fluid, that's third spacing. It should be in the blood vessels, right, in the portal vein, but it's not. And so you might have like this person that looks like they're freaking pregnant, right? You might have in a guy gynecomastia, right? So they have like low androgen levels and whatnot. You might see hernias. You might see on the bellies and whatnot. You might see engorged blood vessels on the abdomen, caput medusa. You might see spider angiomas. So they're usually, I check them right here in the neck, right in the upper chest area, or right here in the face. But they're gonna be like they're called spider veins. But yeah, they look like fireworks, and they're all red and stuff like that, and they kind of just spider out like that, like a web. You would look at their ankles too to see if there's any bilateral edema too, and so if they're pitting and how bad they're pitting. So whenever you're pressing on their ankles, right, and usually it's going to be the medial side of the ankle that you're going to press down and see how bad that swelling is. You can look at their palms to see if there's any signs of palmar erythema, so red palms, but I don't know, if you catch that, cool. Let's see, asterixis too. So tremors. So you're gonna have them classically like hold up their arms like this, like they're stopping traffic, and then have them close their eyes, and you're going to try to bend the wrist back. And as they are, right, they're gonna try to resist. And then if their hands are flapping and beating like a bird, that shows signs of cirrhosis and hepatic encephalopathy. So those are some of the things that I might do just because you're with me, and I could teach you as a student in the room to see if they're cirrhotic. But I can tell you, just you can glean at their labs, right? Their albumin is fine, platelets is good, INR is steady, bilirubin's okay. Like you doubt they're cirrhotic and stuff like. But I mean, you should always check, right? It's part of the physical exam. So that was a mouthful. And so let's go see this patient and see what's up. Okay. So yeah, so this is jaundice right here. See lemon head person right here with the lemon eyeballs. That's jaundice. So this referral is a 61-year-old female. She has history of hypertension, type 2 diabetes. Bear with me with my acronyms. You can always ask in the chat if or my abbreviations if it doesn't make sense. So again, she's referred for her abnormal liver enzymes are a little bit up. Okay, and so we review the labs. Hopefully they brought it with us, or the PCP like fax it over to our office so I can review beforehand. The AST is 89. ALT is 121. People will always know. So the L is for liver, and so the ALT is more specific to the liver and the hepatocytes, as opposed to the AST. And then the alkaline phosphatase is 90. T-Billy is normal at 0.5. Albumin looks good at 4.5. Platelet 250. That's pretty normal. So just based on looking at the labs, and if we didn't even see the patient, mild elevation of liver enzymes, more hepatocellular looking. I don't suspect there's anything going on in the bile ducts. I suspect this person has pretty good liver function. And so we go see the patient. She's like, she's otherwise feeling fine. If you were to see her at your local Walmart, whatever, walking down the aisle, you wouldn't even think she was sick or had any problems with her labs. But so she's without any symptoms, which is pretty classic of whenever I see a liver disease patient, especially outpatient, I mean. But some things about the history that you should elicit are things like, does this person have history of IV drug use? Which is, man, sometimes it's kind of hard whenever it's like somebody with their mother and stuff like that, and you're kind of like, I don't know how to get an extra accurate history with that. But nonetheless, did they shoot up heroin or whatnot in the olden days or when they were younger? Multiple sexual partners and promiscuity. You want to ask about that. Blood transfusions in the past, before they used to screen for like HIV, hepatitis B, hepatitis C. You want to ask about family history too. So, I mean, she's a female, so already you're kind of thinking, she's in the later decades of her life. I mean, this can be an autoimmune related liver disease presentation. Okay. So you want to ask about family history. You want to ask about medications too. I mean, everything under the sun is going to cause headache, GI upset. It's going to cause, probably kidney function stuff and liver stuff. So, I mean, it's just always good to review the medications and the med list before going in. But, she's only on lisinopril. She's on metformin. Otherwise, she's pretty healthy, not taking anything else. You also want to ask about over-the-counter products and herbs that they're taking, including Tylenol too, right? So Tylenol is really important, and you're really considering that whenever, like, if you have a presentation, this is going to be in the hospital, right? Someone presenting with AST, ALT levels, in the thousands, like Tylenol is going to be on the top part of your differential. And, usually it's going to be somebody that's trying to commit suicide or something like that, right? With Tylenol overdose. So we ask about meds, over-the-counter products, herbs, and Tylenol and things like that. And then on exam, her vitals are stable. Her BMI is 38, so she's a little bit on the overweight side, obese side. Her physical exam is benign. And so what are we looking for? Those are the things that I mentioned before, right? The stigmata of cirrhosis. And so I realized when I was typing this up, I forgot. I left out a big part of the history regarding liver disease. Does anyone want to take a stab at it and see what I forgot? Yeah, nice. So, man, y'all are on top of it. So, glucose management control. Yeah, that's important too. I mean, how's your A1C doing, right? Like I can use that later on for patient education, things like that. But A1C is pretty important too. I was also talking about alcohol consumption too. So you want to ask them, how much are you drinking, and try to quantify it and whatnot to see if this is more alcoholic liver disease or if it's something else. And we'll talk about that later. So alcohol use, she drinks, wine, and on weekends when she's getting brunch with her girlfriends and whatnot. At 61 years old, she's still turning up and whatnot. Only on weekends though, like a glass of wine. So, not too bad. She's been doing that for, over 30 years and whatnot. So it's not too bad. So the differential for an elevated liver enzyme workup is pretty broad. So let's see. So we do a lot of screening with a lot of labs. So, okay. So first off, what labs would you want to order next? Would you like to do imaging? Does everyone need a biopsy? So, I mean, as you're taking care of these patients, these are things that you want to think about. So she only had that CMP CBC from her primary care doctor, so that's why she's seeing us today. And then we didn't note any imaging. We asked her, nope, no imaging. So let's get some labs. On the GI side, I'm ordering a whole host, a laundry list of labs. There's gonna be a lot of blood taken out, and I want them that. And then imaging. What imaging would I want to do? Do I want to do a CT scan? Do I want to do an MRI? Do I want to do an ultrasound? I would probably pick an ultrasound just to look at the liver. It's pretty good at looking at that. It's pretty good, pretty sensitive at picking up masses and growths and looking at to see if the liver is enlarged, if the spleen is enlarged. It can pick up cirrhosis, more towards the end of things when you're really fibrotic, not kind of like when you're in the stage like F1 or 2 or anything like that. But yeah, I'd definitely order ultrasound. MR would be good too, but I mean that's not cost effective or anything like that. So yeah, ultrasound is more cost effective. It's non-invasive. So I wouldn't do CT, MRI right off the bat or anything like that. So let's order ultrasound. And then okay, so I had this diagram up here. So this is the venous portal system. Okay, and so you can also have elevated liver enzymes too because of a clot in the portal system. So here you have the hepatic portal vein, and from here you have the splenic vein right here. Okay, the inferior mesenteric vein drains into that. You have the superior mesenteric vein too, and so which also drains into the main portal vein. So if you have a clot right here, a PVT, portal vein thrombosis, that can jack up your liver enzymes. Consequently, if you have a clot so this is the inferior vena cava right here, and so what drains into that from the liver is the hepatic vein, right? So if you have a clot there exiting the liver, going back into circulation at the inferior vena cava, I'm gonna butcher this, but I think it's called Budd-Chiari, something like that. You'll learn about it, and I don't know. I hope to see it one day, but you can have a clot there that's causing hepatic congestion, essentially, and that can jack up the liver enzymes too. So when I'm ordering the ultrasound, I will commonly order it with Doppler. A Doppler will let the sonographer see the blood flow things to see if it's flowing right or if there's any concerns for a clot anywhere. Man, that's good. All right, kind of thirsty. You can see the umbilical vein right here. So people with cirrhosis will also have umbilical hernias too, and that's because the shit's like sticking out and whatnot. So yeah. Anyways, and varices. I probably should have mentioned that. So varices. So all this blue stuff is draining into the liver right here, all into the portal vein, into the liver, and back into the inferior vena cava. But if the liver is so scarred up from cirrhosis, then it's like roadblocks to what would be like flowing blood, and so it's gonna back up. You can have the blood back up into the to the rectum right here, even too. But mostly, you're concerned about blood backing up into the stomach and the esophagus, esophageal varices, which are like you'll hear them being called like ticking time bombs, and they can burst and cause some bleeding, or here in the stomach too. So that's no bueno. But anyway, so we get labs and we get ultrasound with Doppler, and we'll talk about biopsy later. And so, how do you determine hepatomegaly on ultrasound? Well, I mean, they'll just measure the liver and whatnot. Okay, so the panel of labs that you'll do, okay, is pretty extensive. You're gonna check for viral hepatitis, and these are the things that I would order for. Well, we won't go into details. I'll just kind of skim through this. We'll look at iron levels to see if this is iron overload and hemochromatosis type of liver disease. If this is ceruloplasm, that's what we check for Wilson's disease. Okay, copper buildup, and then we can check for alpha-1 antitrypsin for alpha-1 antitrypsin deficiency. And so you get this like misfolded protein that essentially like clogs up the liver. And so it'll cause some elevated LFTs and whatnot. Autoimmune hepatitis. I mean, that's something to consider, right? She's in her later decades of life. She's a female, predisposes her to autoimmune diseases, primary biliary cholangitis, even celiac disease, right? So celiac disease, if you're having celiac disease and you're not staying away from gluten, which is essentially the treatment for it, then you can also have elevated liver enzymes. And we have seen some people with celiac disease that didn't really know it. So they had a mild clinical course that ended up with what we suspect was cirrhosis due to that. Also could have been due to non-alcoholic fatty liver disease as well. But it's kind of cool to consider that, right, in the workup. I get the AFP as a tumor marker just to screen for HCC. That, along with the ultrasound, provides for some good sensitivity. We're checking the INR. Sometimes the PCPs don't order that because, the workup is with us. So I'll order the INR. Again, I'll order the ultrasound with the Doppler. And so other things you want to consider is DILI. That's why we asked about the medication history. DILI is drug-induced liver injury. Statins, a lot of people be on statins, right? Because the American triad is hypertension, high blood pressure, cholesterol problems, and diabetes. That's American triad, right? And so statins are going to be used for cholesterol problem, and they can cause elevated LFTs. But I'll tell you right off the bat, I almost always never stopped at statins. Okay, they're perfectly safe in people with liver disease, even the end spectrum of things, cirrhosis. Okay, they're almost always safe. I can't always save always, but I have yet to stop anyone on statins on my end. And then non-alcoholic fatty liver disease and alcohol. So they can the only way you're gonna tease between the two in the history is based upon how much alcohol they're drinking, if you think that's substantial. But it's a fatty buildup, fatty accumulation in the liver. Over time, it can cause inflammation. Over time, that inflammation can cause a buildup of fibrotic tissue. And over time, the fibrotic tissues start to build up, and then you're left with this cirrhotic liver and stuff like that. So that's something to consider too. And then sometimes to glean into liver disease, of course, you'll see like AST ALT ratio, comparing the two to one, AST ALT. But you can also look at the MCV. If it's a macrocytic, meaning above 100, you're thinking, okay, this could be more alcoholic, that this person is still using alcohol when they claim that they don't. It also could be due to B12 folate deficiency, which your alcoholic patients are classically vitamin deficient. You could glean into the GGT as well. That's another lab marker. So yeah, see, it's a lot. That's why I really like working this up. But usually it's like all negative, and most of the time it's like non-alcoholic fatty liver disease, right? So, but anyways, the labs come back. So you're no longer with me, but I just, I'm like, hey, this is kind of what happened with the patient. So I tell you that the labs come back a few days later. It's unremarkable. And oh yeah, this person needs a Hep A, Hep B vaccine too. And so the ultrasound said that they have fatty liver. Otherwise, it's pretty normal. And so question is liver biopsy or not? I'll tell you that we generally do not get a liver biopsy on everyone. That's not really cost effective, and it's overdoing it because generally if they screen negative for all of these the battery of labs that I ordered, right, and they have the right risk factors, metabolic risk factors is what we talk about, like high blood pressure, the cholesterol, the insulin insensitivity or resistance, right, i.e. diabetes, and they're obese, then probably you're thinking, all right, this is non-alcoholic fatty liver disease, and usually liver biopsy is not warranted. Okay, so we opt to not do a liver biopsy at this point. If they screen positive for something, and I'm suspecting PBC, primary biliary cholangitis, or autoimmune hepatitis, or hemochromatosis, or things like that, I probably would consider a liver biopsy. So, but in this case, slam dunk, we think it's non-alcoholic fatty liver disease. And so I brought this up because NAFLD D is what you'll hear it referred to. It's a lot of patient education, right? There's no real treatment for it. There's no magic pill or whatever. And so, I mean, it's weight loss, losing 10% of your body weight, they say in 6 months will do you a whole world of good. It's exercise. And I always encourage them, just walk 50 minutes a day, right? Like, I mean, you might be the only person to really empower them in the like short 15 minutes you have. So just, be their hype beast. That's what I try to do. Like be their hype beast, steer them away from all of the, gimmicks and stuff out there. Just be their advocate and just start with 15 minutes daily of walking. And if that's all they ever do, then that's pretty Gucci, you know. Um, Consider a referral to a dietitian if you have that resource within your community. I think that's always a plus because we as clinicians don't have enough time, and I don't think nutrition is not stressed as heavily in our didactic training and whatnot. So if I can send them to a dietitian, if insurance will approve it, I send them off. You know what I mean? Minimize alcohol use, of course. Easier said than done, right? And then we'll do I tell them that fatty liver it's a sign from your body that okay, some things should change. I tell them like it's your body telling you, hey, I mean, we should work on some things. It's irreversible. You can reverse this essentially with good weight loss and a good diet and whatnot, being active. um, you're essentially predisposing you to cardio risk factors, right? To heart attacks and whatnot, coronary artery disease, and things like that. On top of the cirrhosis too, the liver, that direct liver insult. So it's a lot of patient education. Like I said, there's not a magic treatment for it or anything like that. But as PAs, we do get more time with the patient. So I mean, like I said, be their hype beast. Okay. So man, I need a break. All right, so we see like other patients and everything. So it's freaking busy morning. I only close like half the charts per usual, and so I have to catch up later. It's lunchtime. I like to eat, so I take that seriously. So we go to the physician lounge. I hook it up, and then at this time, I've seen some students, they're so engaged in their phone and everything like that, and I'm like, dude, that's just not cool because you're probably taking the spot of someone else's shadowing time. So that's why I included it on there. Especially I want to say I got to get on my soapbox real quick with the advent of social media on Instagram, people DMing other PAs to shadow. Like you're taking the spot of somebody that's probably more engaged and not wanting this for just the hours. So I would encourage you to stay off your phone because this is valuable time. It's hard to get you in the clinic. It's hard to get you a spot to shadow. And so just be cordial. You should be asking us questions. I mean, this should be a whole experience for you to learn something, right? So check your phone later. And then, so we're eating lunch and everything. It's probably like, fake Panda Express in the physician lounge, which I actually kind of like. So, but anyways, as per usual, we'll get a new console at the most inconvenient time as we're eating. So we got to scarf that up real quick. Vamos on to the next one because we still got to grind throughout the day. Oh, so by the way, we just finished clinic and we'll go over to the hospital in the afternoon. So that's what we're doing. So our next case is going to be somebody, let's see, a 40-year-old male with epigastric pain. So again, kind of underneath the breastbone. And he's had this for a day now with lots of nausea and vomiting. He does tell you like, hey, I use a lot of alcohol, which you always thank him for the honesty, right? That way we could better treat him. And then he has increased his alcohol use, he admits, lately because of the pandemic, right? People are losing their jobs and whatever. And so, you also know whenever you're doing a chart review, this gentleman, John Doe, he's been here twice before this year for similar presentation and whatnot. So on presentation, his vitals are, they're looking okay. His blood pressure is a little soft. He is, slightly tachycardic by definition, but he's stable. VSS, vital signs stable. AF, afebrile. His labs show that his creatinine is a little bumped up. His transaminases are slightly elevated. Bilirubin is kind of up. Alk Phos 290. So, okay. And then his lipase though, right? Because he complains of abdominal pain. So we kind of just order a lipase, especially if it's in the epigastrium area, right? It's 3,000. Okay, that's pretty high. And then on exam, he is tended to touch over there. I mean, he kind of wants to sock you in the face for just touching that area, but you do it anyways. And then the ED people, they have already gotten the ultrasound, and it shows no gallstones, which is going to be important. But they do say like, hey, the common bile duct is a little bit dilated at 9 millimeters, and it does taper distally. So, you know, it's dilated and then it narrows like that. And then they do get a CT as well. And so my question to you is, did they do the CT because they were suspecting a pancreas? I just gave it away. Okay, we're suspecting like a pancreas insult right now. Did they get it with contrast or without contrast? Anyone know? So it's going to be with contrast. So you need that IV contrast to really look at the liver parenchyma and the tissue. So they did get a CT with IV contrast. It does show, you know, fat stranding, consistent with acute pancreatitis, but there's no complications noted. Okay, and then again, they showed this common bile duct is a little bit dilated. All right, so let's kind of revisit. We have this 40-year-old dude. He's an alcoholic drinker, or he's an alcoholic, extensive alcohol use. He's been drinking a little bit more with similar presentations in the past. He does show some, what would be, you know, this could be considered a cholestatic pattern right here, I would say. His lipase is elevated. So, of course, he has pancreatitis. Okay. And the ultrasound shows there may be something going on in the common bile duct, which I would also endorse because the bilirubin and the alk-Phos, they're elevated, right? So, okay, so the team agrees, hey, we got to admit this patient. Let's get GI on board too because he has pancreatitis. And so we suspect it's secondary to alcohol. We should probably work up so the abnormal imaging here is this common bile duct and the elevated bilirubin and alk-Phos and stuff. So, you know, we're thinking about other causes of pancreatitis, which is pretty broad too. I mean, the most common two things that you should remember at least is alcohol use and gallstone pancreatitis, right? So gallstones, you know, dropping into common bile duct and then it gets stuck or whatever, and it causes, you know, a backup of the pancreatic juices, and then it starts to, you know, cause degradation of the pancreas and inflammation and whatnot. So those are the two things. But on ultrasound, no gallstones, right? And he does, you know, you should ask, hey, do you still have your gallbladder? But other causes are hypertriglyceridemia. So, you know, if you're floating around with triglycerides above 1,000, essentially you got like bacon grease in your blood. That's going to predispose you to pancreatitis. You can have drug injuries too, kind of like DILI for liver. You can have drug-induced pancreatitis. You can have, you know, hypercalcemia. I haven't seen that yet, but high calcium level, serum calcium levels. You can have cancer even, cancer presenting as a pancreatitis as well. So just all things to consider. But here we got we got a slam dunk history because we're freaking badasses, and so we think it's alcohol. So management of pancreatitis, if you're going to take away one thing from pancreatitis is I just want you to flood this dude with fluids. He is so thirsty, okay? Just imagine that pancreas is like a little sponge and it is absorbing all the fluids, just an analogy-wise. And so whenever I'm treating pancreatitis, you know, I'm actually not monitoring the lipase, as counterintuitive to that might be. Like, once I see the lipase at 3,000, right, I have the diagnosis now, but I don't need to trend it, right? We trend things like the creatinine, we trend things like the BUN, the hemoglobin, the hematocrit, because we want to make sure that this dude, that this gal, whoever has a pancreatitis, is getting so much fluid, all right? It's just like a tsunami, okay? Like for real. And so I would be like, yo, if he's in the ER, give him like 2 boluses, run the third bag of saline or lactated ringers, probably even better, you know, but whichever, at like 250 cc's, like we're flooding him, okay? And pain management is paramount too. Nutrition, you want to keep him NPO in that you don't want them to throw up anymore and whatnot because they're, you know, he was nauseated and vomiting. But I will say that don't be afraid to start them on nutrition if they feel up for it. If it's like a mild pancreatitis, and then the next day, they feel better, the pain is better, and you want to trial them on some liquids and whatnot to kind of get them going, then, it's fine. We don't have to keep them NPO for like, 48 hours or whatever. You want to consider stopping offending medications, like classically like your diuretics and whatnot. And then I always start them on a bowel regimen because if you think about it, they are getting pain narcotics, right? So they're getting morphine, they're bedbound, immobile, they're not getting enough nutrients. So I always start them on a bowel regimen just to see if I can get their bowels going at least. And then specifically in this case, this is not in every pancreatitis case, we're going to work up that common bile duct that's a little bit dilated, right? So we get an MRCP, and I'll show you what that is later. But the MRCP is going to look at the common bile duct, the biliary tree, all that green tubes that you see on the anatomy books. And so we're concerned to see if there's anything blocking the common bile duct, causing the cholestatic liver pattern. And so it shows, all right, there's no stone or anything like that. But, it does, it's dilated, it's tapered. And so in this case, we're thinking, okay, he has history of recurrent pancreatitis, right? And in this case, he probably has an inflammatory stricture secondary to the pancreatitis. So, I mean, your pancreas, just the way that the anatomy works. If your pancreas is inflamed and whatnot, it touches up against the bile duct, right? Your bile duct runs through the pancreatic head. And so if the pancreas is inflamed, it can cause some irritation to the bile ducts. And so that's probably what's happening right now. So, we decide, all right, it's narrowed. We don't want to wait for this to get any worse. He can get septic from it and whatnot. So let's go ahead and put a ERC. Let's do an ERCP. I'll explain what that is later. And stent this dude. Put a stent up there to provide for better flow of the bile, right? So acute pancreatitis complications. You're thinking of things like portal vein thrombosis, a splenic vein thrombosis, so they can clot, right? They can have ascites from the pancreatitis. They can have a full-blown, they can get septic from pancreatitis. They can have a necrotic pancreatitis. So there's a lot that can happen. They can have an ileus too. So, the pancreas, it's pretty you should respect the pancreas is what I'm going to say. And so when we're rounding on patients every day, by and large, a lot of people with mild pancreatitis would do well, which is great. But you want to make sure you're monitoring for such complications too, even like fluid overload, right? Like we're like giving them a whole tsunami full of fluids. And so you want to make sure that you're not overdoing it, right? Like they're not shortness of breath and having a fluid overload here in the lungs, or, their legs aren't swelling up too bad or anything like that. So we want to make sure we're not harming them as well. Okay, so look at this wrap. All right, what is this wrap looking like? So we are wrapping up with this patient. So he has a very mild course of interstitial pancreatitis, if you will. Does well with IV fluids. So he gets that ERCP in the stent, and we watch him for 24 hours, basically the next day after the ERCP to make sure there's no complications and whatnot. And he's doing all right. And so pretty stellar. So basically he does well. He's able to leave. We say, hey, stop the alcohol use. And then he needs to follow back up though, because we place a plastic stent. And so when you're placing that plastic stent, you don't want that shit to get like infected or anything like that. So it's only temporary. So he's probably going to follow up with you, the PA, or us, the PAs, in clinic. Probably about 6 weeks after the hospital visit. And then we'll set him up for an ERCP, remove that stent, and hopefully, he's going to stop drinking and whatnot. Because, these pancreatitis episodes are not fun, and they're probably painful. It probably sucks. So that's that. All right. Let's see how I'm doing on time. It's like an hour and 20. Okay, cool. I think I could finish up. So we have one more case, and then we'll wrap up. So brief intermission. We're rounding on patients. We're finishing up, and then boom, like freaking A, we get another consult at the most inconvenient time because that's the best time for a consult. And so, as we're about to leave and whatnot, I get another consult. And so, let's go, man. Yeehaw. So we go see this person. But before we see the consult, I just want to let you know, like, even if you're a student or whatever right now, or whatnot, like, you all have a role in during this time with the COVID and whatnot, because even though I don't treat COVID directly and whatnot, I still try to make it as easy and seamless as possible when I'm treating these patients that I'm consulted for. Because if you think about, like, the hospitalists, they have like 15 plus patients on their census. They're extremely busy. And so if you evaluate the patient, you take care of that one problem they consult you for, you put in the orders, you line up the procedure, and you just, like, I'll send them a quick text like, hey, this is what's going on. This is when we're going to take them back to the GI lab and scope and whatnot. Like, they're super appreciative of it. And, just any little help you can give them so they can concentrate on other things too, it's going to be a world of help. So, but anyways, off my soapbox, we go to the ER because we get a consult for an upper GI bleed, which is quite common. So, upper GI bleed. So we get this 70-year-old chick. She has history of coronary artery disease. She has had a stent back in 2012, and she has some kidney disease too. So because of that stent, she's been on Eliquis, a blood thinner, and aspirin, 81 baby aspirin daily since. She's presenting to the ER because she's fatigued, just generally tired. She notes some melanoma, which is that black tarry stool stuff that started yesterday. So she finally decides, I gotta go to the ER or whatever. So she goes to the ER. She gets admitted for GI bleed and anemia. Okay. On exam, her vitals are stable, which is paramount, right? Anytime you want to make sure they're not like exsanguinating a lot of blood, and then they're hypotensive, tachycardic, and they just seem unstable. You decide to do a rectal exam, and so you look at the booty hole, and it does show some melanic stools. It's black, it's tarry, it's truly black. So you got to wipe it against something white to really get a good. Anyways, her hemoglobin is 8.9, and then you do some chart reviewing. You see, her baseline is usually at around 11. Okay, low 10s, 11, whatever. So, I mean, there is some drifting from the baseline. Other things I look at are the BUN creatinine. It's 35. So anytime it's more than like 30, you're concerned about an upper GI bleed. That's a good pearl. And her INR is 2.7. So it's probably that high because she's on Eliquis, right? So, anytime we're about to do a procedure or whatnot, and it's a GI bleed, they're on blood thinners, I need to know what that INR is looking like. Ideally, you want it to be less than 1.5, but, she is on a blood thinner and whatnot. And so I also always ask if they've had prior endoscopy done before, just so, there's no surprises whenever the attendings go do their scopes. So my question to you is this an upper or a lower GI bleed? I think I kind of already gave away the answer to that. You want any differentials, plans? Should I transfuse? Any stabs at any of those questions, peeps? Yeah, I definitely think this is an upper GI bleed. You had that melena, so as that blood is trickling down the GI tract, it gets oxidized and it turns black and it's foul smelling. And so that BUN creatinine is also elevated too. So just based on that, you're thinking, okay, this is probably an upper GI bleed. So nice. So some differentials. We can think about things like we talk about peptic ulcer already. So this could be an ulcer that's freaking bleeding out. This can be really bad, like erosive esophagitis, and you're just kind of like thinning the mucosa and whatnot. You can think about cancer. Cancer is always on the differential, right? So you can think about gastric cancer. You can think about esophageal cancer. You can think about AVMs, which are just basically blood vessels that bleed, right? Malformations, arteriovenous malformations, things like that. Okay. Other scary stuff that are upper GI bleeds and stuff. You're thinking about a cirrhotic with hematemesis, which is buddyblomatis. So that's the ticking time bomb, those esophageal varices that I talked about, or it could be gastric varices that they just pop and then they're just hosing out blood, and like, you're just like shit. So you will get a consult late at night at 2 a.m. because of that. So it's a GI emergency. But in this case, probably not. And then let's see. So we talked about some things on the differential plan. If I think this is an upper GI bleed, I'm probably going to do an upper endoscopy, right? Right. So good job. And then shall I transfuse or not transfuse is the question. So should I give her blood or is she Gucci at a 8.9 or whatever? So to harp on this, she likely needs an EGD, upper endoscopy. Pretty cool. And then I do ask, that they stop, and the primary team usually does this already. You stop all anticoagulants because they're having a GI bleed, right? That's the immediate issue right now. They're probably going to be okay being off of their blood thinners for the time of this admission. The INR, I guess, you want it less than 2, ideally less than 1.5, but here this INR at 2.7. If they need the EGD, then they're probably okay. There's no legitimate reversal for apixaban. Some might use Kcentra, which is a reversal agent, but reversal agent meaning like if this was warfarin, then we can quickly give them some vitamin K or Kcentra, and that can reverse their coagulopathy, right, and get that INR at a more ideal number. But it's okay at 2.7. Just take my word for it. Let's see. Keep NPO because we're about to do a procedure. So you don't want any risk with anesthesia and them aspirating shit into their lungs and whatever. So keep them NPO, and then we're going to serial their H&H, meaning we're going to follow it. Whether it be Q8 hours, Q6 hours, whatever, depending on each case. And then transfusion wise, the protocol is just based on a study. I'll just say that, keep it simple. And GI bleeds, if it's less than 7, then we're going to transfuse. Sometimes you want a goal of 8 if they have like coronary artery disease or something like that. You want it at around 8, 7 to 9 if they're cirrhotic and whatnot. But I just threw that in there because she is not less than 7. She's pretty stable. I don't think she needs any blood transfusion, blood products at this point. So those are my thoughts. Okay, so we do EGD. Never mind his colonoscopy. I just have it on there. But it's the same guy. But I think our patient was a female, right? Whatever. So she is now in the endoscopy room. She's getting her EGD from our attending. And I just throw in this colonoscopy in there just to say, like, this is the other procedure that GI folks will usually do too. And so, I mean, it's just like the reverse EGD. We're just going up the ass and then circling around here, going to the end of the colon, which is the cecum. And the only caveat here is that they got to take a prep. So they got to like purge their bowels so that it looks shiny and glistening and stuff, because you don't want to see poo splattered everywhere, right? Because you don't get a good look at the mucosa. So that's that, just FYI. And then, so wrapping up this case, she had the EGD, and we found some AVMs, right? So this just bleeding vessels. Well, let's just say it's in the stomach. So your attending clips it, he cauterizes it. He could have done epinephrine injection, whatever. But anyways, he gets successful hemostasis, meaning he stops the bleed and he feels good about it. And then next day, you're rounding on the patient. The hemoglobin is at 9.1. So it's not like the hemoglobin is going to go like back up and everything like that. But, it's pretty stable. And so she has no more bleeding since. But you can expect some more melena after this procedure because we just like cauterize some stuff and whatnot. So she's stable, and later she is gone. She is good. You'll probably see her in the clinic and whatever. So I think that wraps up our at our shadowing time, right? So we dip out before we get another consult or whatever. And so I wanted to just briefly tell you about the other cool scopes that we do in GI. So we have an EUS procedure. Again, they all look like long tubular cameras, but with the EUS, they have an ultrasound probe at the end. So we can look at things like the pancreas, we can look at the liver and stuff like that. We can take biopsies of the pancreas. So it's just an ultrasound probe at the end of a camera. So it's pretty cool. So you get images like this. And yeah, you can look at the common bile duct here, and you can see like a stone right there. The common bile duct is dilated, and it tapers distally and whatnot. So it's pretty cool. MRCP is just an MR study, but it gives us such a detailed look of the bile duct tree and the gallbladder and whatnot, and the pancreatic duct and stuff right here. So that's just strictly diagnostic, right? The ERCP is an endoscopy procedure. So it's not only diagnostic, where we can also look at the biliary tree, but we can, as you see right here with the endoscope, we can go into there. We can retrieve stones up here in the bile duct with a basket. We can place stents in there. We can go into the pancreatic duct right there, retrieve stones, put stents in there too. So ERCP is more invasive, of course, right? And you can always cause some post-ERCP pancreatitis inherently. So those are just some things to know. These two right here are procedures, and the MRCP, if you're ordering it, you're telling, you're noting that, hey, I just want to look at the biliary tree. This is a non-contrast study. And so it's, it's just radiology. All right. So that was a pretty long day. All right. We got some good workups and stuff like that. You got your food. So we're just concluding. So, before you dip out, we head back to the physician lounge, get you some more coffee, snacks, refreshments, whatever. And then we talk about key points. And then I always encourage people to bring their hour log, just because it's nice to have some proof too. I doubt anyone would ever be anal and ask for it, but it's nice to have. And it's going to be a lot easier when you're doing your CASP application at the end to just, have things already organized and whatnot. So I always encourage people to bring an hour log thing, and I happily sign. And then, yeah, so this is my crew right here. In the front row, you have the amazing providers that I work with. We have the doctors here in the middle, and we're missing one, and then they're capped with their freaking badass PAs and whatnot. So you know what I mean? So yeah. As we wrap up the day, I'll talk about, my pro tips I try to leave with you. I try to be practical, so studying wise, I would just say, just focus things on a primary care focus, right? Be as broad as possible and don't get stuck in the rabbit holes and whatnot. Money is important too. Finance is important. So, get that free money, get the scholarships. They're tax free. Even if it's a $500 scholarship, it's going to do you wonders. Okay. Trust me. So just mass apply, shoot your shot, apply for 100, get one. That's awesome. That's a win right there. And then just start networking right off the bat, because at the end of the day, like I said, you're in this for yourself too, not for the intrinsic altruistic means of being a provider and a PA, but you also need to take care of yourself. You need to take care of your family, right? Health is wealth. So start networking so that you're better equipped to find a good position later on in the future as you graduate and matriculate. And I say it's a two-way street too. So like whenever I'm seeing, students, I've been on the game for a while. Okay, not a long while, but long enough to where I'm like, I don't even like Casper and the PA MCAT stuff. I don't know anything about it. So I'll ask you about it. So I'm using you as a resource also. So, it truly is a two-way street. And so I'm trying to learn something from you too. So yeah, that's just kind of, burnout is important too. I always encourage people to find out what makes them happy and what keeps them, what kind of recharges them and whatnot. So find that remedy. And then, for me, it's just getting out into nature or leaving Dallas or whatever and doing something fun and leaving work here as I go do some shit somewhere elsewhere. So those are, that's what I'm doing. And so I hope you had a good day shadowing me. I hope you got something from it. At least you got free food, right? So that's always a plus. And yeah, that's me. That's my Instagram handle. And I guess it'd be a good time to do a quick Q&A and whatnot. That wasn't too bad, right? I was like an hour and a half. And I guess I could just scroll through the questions on YouTube Live.
Yeah, exactly. There were quite a few of them that just came through.
You wanna just let's see. I'll read through them.
Yeah,
you wanna help me pick and choose which questions?
Yeah, sure. Let's see.
So it's less pressure on myself.
Yeah, absolutely.
All right, yeah. I'm gonna defer to you, bro.
So somebody wants to know why you went into GI, like why you chose that over all of the other electives, specializations.
Oh yeah, so I went into GI because it just made sense to me. So as I was going through my clinical blocks and stuff like that, I'm always like a big fan of triple down on what you're good at, meaning like cardiology just didn't make enough sense to where, it just like I vibed with it to where I didn't have to relook at it over and over just to be like, oh yeah, that's what's happening. It just made sense to me and I felt comfortable with it. I like like I said, the broadness of it and how deep I can go into the topic. I like, how, I mean, it's very like you can talk about the upper GI stuff. You can talk about just the liver, the pancreas. It's just so cerebral, so interesting. And I would recommend, working smarter, not harder. So, I mean, if you weren't meant to be in like rheumatology or like GI or whatever, then just pick something that you're good at. And, that's probably where you belong, right? That's where you belong as part of the team, right? So, like, as part of the team, I'm focusing on the GI stuff. If it's like cardiology related, go see some other guy, So that's kind of how I think about it.
Cool. So kind of on the flip side of that, somebody's asking, what don't you like about your job? So
I guess pros and cons. Being a new grad and whatever, maybe still or whatnot, or in the beginning, like patients are gonna test you, especially if you're young looking too. They're gonna test you, they're gonna be skeptical, I guess I would say. Your colleagues will be skeptical of you too until you kind of show them that you can handle what you can handle, that you're not shy, and you're honest about seeking advice or seeking or keeping your attendings informed, like, hey, that's a very good question. I will need to I'm going to discuss with my attending physician before I provide you a more clearer picture of what the management would be like. And so I mean, most people are receptive of it. Of course, every now and then you're going to get that gripey person and whatnot. Other things, pros and cons of working, some people will say, with more than one attending and stuff like that. So the pros with working with myself with 5 attendings is I get to learn 5 different flavors of doing GI for like a particular condition, if you will. But I mean, on the flip side, I also get 5 different, like this doctor would do this for that, but this doctor does it differently. And so you're kind of like, depending on who the doctor is, you kind of morph your management plan, if you will. So that can get kind of complicated and can be difficult at times, so something to consider. And I guess I'm not doing procedures too. So if you're really like hands-on and you're just like, I just need to fix something with my hands and whatnot, then, the GI world is very limited in that sense.
awesome. Are you okay with doing maybe one more?
Yeah, I could stick around for like 10 more minutes if y'all want to hang, whatever.
Yeah, cool. So Mia Crowd is asking, has a patient ever been so dishonest with you with past medical history that it led to complications with treatment? And if so, what's the best way to handle that kind of situation?
Oh, dang, man. I feel like I'm being interviewed for like P school or something.
I know, put you on the spot.
Let's see. Lied to me. I mean, I don't know. I guess there was one patient that was more of like a drug seeker and everything like that. And so, it's pretty difficult. She was, she had comorbid conditions that weren't her fault. And, I could see why she is the way that she was, and that she could be manipulative towards the staff, the providers, the nurses, whatever. And so, I when I first met her, I could like she just like smelled fresh blood. Like she was like, oh man, this is freshman right here, you know? And so I could tell that, like at first, I had to let go of the bias and whatnot. She's still a patient no matter what. And so I gave her my time and everything like that. But, over time, I can only do my best and give her my best advice. And so I can't technically let the patients like dictate care. And so if it escalates to that level, first thing you do as a PA is get your supervising attending on board, get their thoughts. Maybe it removes that cloud of bias that you might have, and then if they also agree with the plan, talk it over with the consulting physician too. Like, this is what I think is going on, and then just take it up that hierarchy like that. But I mean, you should, I guess, in this lesson, like the bias is going to be there, but it should never derail you from giving them the proper workup that they deserve. Even if she's been here multiple times for the same reason, if she's narcotic seeking, she still deserves as a human being that same proper workup you would give to somebody else, to somebody that you love too. You know what I mean?
Yeah, that's awesome. That's a really good answer.
Oh shit, nice.
Yeah, that was really good, man. But let's see, maybe one more. It seems like they're kind of slowing down. So do you have recommendations on PCE, like types of PCE? Is there like a tier list of some things better than the other? What did you do?
I got lucky at UT Southwestern because they counted my pharmacy technician hours as like hands-on, if you will. But I mean, it depends. If you're asking me, I will say practically speaking, if you're an MA or a scribe, you're probably going to get more transitionable experiences that you can use, throughout PA school. If you kind of want to, work the system a little bit, you can be like a PT tech, like volunteer or something. I mean, it's still technically hands-on, but I mean, you're not going to get a lot of clinical experience from it, but it still counts. I guess you check with the schools to see if farm tech counts too. It's always nice to know your pharmacology. That topic is pretty dry, it's pretty vanilla, but you're like, you don't get that clinical intuition and stuff like that with working with as an MA or scribe, but I mean, that can also count too. So, I mean, it kind of depends, do you want to, are you just trying to get hours or are you trying to get some like hardcore experience? If you are a scribe, honestly, I would not be an ER scribe. I think the hours suck, pay sucks. But I mean, again, you're gonna get good experience, but you can also be like a scribe in a family medicine clinic, or we have scribes at our GI clinic for the doctors and stuff too. And so they are generally more relaxed and easygoing, and you still learn a lot too. So maybe do something like that.
All right, awesome. All right, I think we
Yeah.
can call it there if you're okay with that.
Dude, I am super cool with calling it that. I got
Yeah.
some ramen noodles
Yeah.
that I'm gonna cook up and eat, like I'm still in college. But yeah,
All right,
um,
awesome. Well, thank you so much. That was a great presentation. It was,
That was
a lot of
really, really cool, really unique how you kind of like took us along virtually. We appreciate the
Sweet.
lunch.
yeah,
Yeah,
thanks for lunch, for
food
sure.
for thought. Yeah. All right,
Well,
cool. Y'all have a good night. I appreciate the invite and everything like that. Okay.
absolutely. Yeah, thank you so
Yeah.
much.
All right. See y'all.
Take
Bye.
care. All right, everybody. So we'll go ahead and get that quiz out in the chat right now. We'll also post it on the Instagram link tree. Like she said before, we just need 4 out of 5. It should be pretty straightforward, nothing like tricky or anything like that. We'll have those certificates mailed out usually within the end of the week, but we try and do a little bit faster than that. So realistically, you're looking at the 2-3 days.
Yeah, maybe in about 1 to 2 days. The last one we got out all of them the next day, so it shouldn't be too long, but just about 1 to 2 days.
Yeah. And aside from that, just stay tuned on our Instagram page. Like we said before, it's going to be really busy this November. So good opportunity for you guys to get a lot of those shadowing hours and a lot of good experience from a ton of different specialties. The next one we have is coming up this Friday, and then we'll have a few more like really quick right afterwards. So next week is going to be busy for you guys. Good opportunities. But aside from that, just thank you so much again. We really appreciate it. That was an awesome presentation. We really enjoyed it. I know I'll be referring back to it on YouTube. So if, you know, something comes up, you end up shadowing GI, you have a question about it, or even any of those helpful tips that he shared with you guys, like it was a lot of good information. So feel free to refer back to it anytime if anything like that comes up.
Yeah, all of our sessions are saved to our YouTube channel. So if you ever need to go back to it, even whenever you're filling out the information on CASPA, if you want to get a refresher to kind of describe how this experience was for you and what you learned, you can just replay the video. And I just sent the link for the quiz whenever you guys are ready. It's open for 1 hour, so it'll close at 10:15 Central.
All right, guys, I think that wraps up this one. So we'll be hanging out in the chat if you guys have any questions or anything like that. We'll probably stay here for 10-15 minutes. All right, guys, we'll see you next time. Thank you so much.
Thank you so much.